Do critics of biological psychiatry have an alternative to a life of whack-a-mole? This is printed in Mad in America, Science, Psychiatry, and Social Justice. As soon as one theory is discredited, the advocates of a biological paradigm turn to another, putting forward a new set of ropey, inconclusive, and ambiguous studies as putative evidence. Challenging the biological model of depression feels like a game of whack-a-mole. As soon as you put one theory to bed, another sprouts up. This is Joanna Moncrief, written in Chemically Imbalanced, 2025. Establishment psychiatry has recently switched the biological cause of mental illness from a chemical imbalance to a brain circuitry defect. There is no more important institution in establishment psychiatry than the National Institute of Mental Health, and in 2022, psychiatrist Thomas Insel, NIMH director from 2002 to 2015, stated in his book Healing, the idea of mental illness as a chemical imbalance has now given way to mental illness as a connectional or brain circuit disorders. Nowadays, establishment psychiatry is turning to ketamine infusions and injections, not only for so-called treatment-resistant depression, defined by them as occurring when at least two different antidepressants don't improve your symptoms, but also using ketamine for post-traumatic stress disorder, PTSD, obsessive-compulsive disorder, bipolar disorder, and anxiety disorder. This turn to ketamine is occurring despite the fact that the FDA has repeatedly warned that the FDA has not approved ketamine for treatment of any psychiatric disorder, although controversially approving S-ketamine nasal spray. Apparently unconcerned by this FDA warning about ketamine infusions and injections, leading figures in establishment psychiatry, including key thought leaders in university psychiatry departments, are enthusiastic about it. John Crystal, chairman of the Department of Psychiatry at Yale, tells us that we think that one of the things that ketamine does that helps to explain its antidepressant effects is to help the brain to grow the synapses, or the connections between nerve cells. While researching psychiatry's current ketamine enthusiasm for the Counterpunch article, Psychiatrist's latest insane magic bullet treatment for depression, why ketamine? And it felt like I was forever playing the arcade game of whack-a-mole. Shortly after the article was published in early 2025, I received a pre-publication of the Chemically Imbalanced, the Making and Unmaking of the Serotonin Myth by psychiatrist Joanna Moncrief, and on the page 177, I discovered that she'd come to the same whack-a-mole conclusion. Whack-a-mole number 1, the chemical imbalance theory. For the last 50 years, prior to its recent pivot to connectional or brain circuit explanations, establishment psychiatry has told us that mental illnesses are caused by chemical imbalances in neurotransmitters such as serotonin, norepinephrine, and dopamine. One such chemical imbalance theory, the so-called dopamine hypothesis of schizophrenia, was discredited in the 1980s. It's now acknowledged as invalid by prominent figures in psychiatry, and some of whom are puzzled by its persistence. For example, one of establishment psychiatrists' most prominent researchers, Kenneth Kendler, noted in 2011 that although the DHS stimulated much science, most efforts to empirically validate it have failed. Nonetheless, the DHS has held the status of a scientific paradigm defended by some with great avidity. And today there remain psychiatrists who take this theory seriously. One major reason for some psychiatrists' avid defense of the DHS is their observation that patients diagnosed with schizophrenia have a reduction in some symptoms, especially those related to agitation, when medicated with antipsychotic drugs that block dopamine. The belief that there is evidence that dopamine excess is a source of schizophrenia is as scientifically unfounded as the belief that a reduction in social inhibition after the consumption of alcohol is proof that shyness is caused by an alcohol deficiency. Establishment psychiatry has shown this same unscientific thinking in its manufacturing of other biological theories of mental illness. Psychiatry has offered various chemical imbalance or monoamine imbalance theories for depression. In 2000, in Depression, the Case for Monoamine Deficiency, Pedro Delgado, one of psychiatry's most prominent researchers of this theory, reviewed the case for the idea that the underlying pathophysiologic basis of depression is a depletion in the levels of serotonin, norepinephrine, and/or dopamine in the nervous system. Delgado concluded that intensive investigation has failed to find convincing evidence of a primary dysfunction in this specific monoamine system in patients with major depressive disorders. In Concrete Chemically Imbalance, she points out that researchers have disproven these various chemical imbalance theories in the late 1980s, when the chemical imbalance theory of depression should have been dead in the water. Establishment psychiatry is still in the process of getting all of its members on board with the switch away from the serotonin imbalance theory. Apparently, not having gotten the memo, the president of the American Psychiatry Association, or APA, told the podcaster in 2023, "We know that serotonin has been strongly associated with depression, and antidepressants work on neurotransmitters, the chemicals in the brain, to rebalance the relative levels." The idea that serotonin is crucial to depression has been difficult for establishment psychiatry to relinquish, because this belief has been long used to convince depressed patients to take serotonin-enhancing drugs, such as selective serotonin reuptake inhibitors, SSRIs. Establishment psychiatrists, ASF, holding on to a serotonin connection with depression, tells us the idea that depression is caused by low levels of serotonin is only one way in which we might understand the relationship between depression and serotonin. In Aftab's 2025 attack on Joanna Moncrief's Dummy's Guide to the British Professional leading the controversial backlash against antidepressants, he tells us that there are many other ways that serotonin may be related to depression, and offers a few such theories. Depression, generally or in some subset of patients, involves alterations of the serotonin signaling system. Example, the distribution or sensitivity of certain sorts of serotonin receptors. The serotonergic system mechanistically links depressive symptoms and neurobiological dysfunctions in other aspects of brain functioning. And the serotonin system is generally involved in the regulation of mood and temperament, and there may be no specific abnormality in the serotonin system in depression by large, but it still provides us with a target for intervention. Really, with serotogenic antidepressants. These people are such hypocrites. Aftab's Dummy's Guide may be taken seriously only by those with little regard for the scientific method, he points out. Aftab's basic point is simply this: although we haven't found them yet, depression might be associated with specific brain processes, including those involving serotonin, and because it might be, we should assume it is. This argument inverts the most basic precepts of science. An idea or theory is unproven until it is proven, not the other way around. This has to be the case because anyone can propose anything, and they do. And there's scores of theories about links between this or that biological process or chemical and depression. The latest Whack-A-Mole, brain circuits, and ketamine. While some establishment psychiatrists, such as AFAB, continue to hold on to the unproven serotonin theories of depression, others promote brain region theories of depression. Harvard Health Publishing and What Causes Depression reported in 2022 Research shows that the hippocampus is smaller in some depressed people. In addition to these theories, today's cutting-edge members of establishment psychiatry are offering up new neurotransmitter theories and repurposing old drugs to fit these theories. For example, in the International Bipolar Foundation 2017 presentation, Ketamine, Glutamate, and the Future of Mood Therapeutics. Historically, psychiatry has simultaneously offered multiple biological theories of depression and other disorders. But the theories that stick around are the most effective marketing devices for money-making drugs. The serotonin deficiency theory of depression sold SSRIs, and today the selling of ketamine infusions and injections rests on theories about how ketamine affects glutamate and the MDMA receptor. While the serotonin imbalance theory of depression was simply wrong, it did not seem bizarre when it was proposed. In contrast, the claims today by cutting-edge psychiatrists of ketamine helping to regrow synapses, or that ketamine is a brain fertilizer, appear wacky in the face of what is known about ketamine's toxic effect on the brain and other organs. Specifically, in 2024, internist and epidemiologist G. Caleb Alexander, co-director of the Center for Drug Safety and Effectiveness at Johns Hopkins, told Psychiatric News that there's lots of evidence that ketamine is toxic to neurons, and it's toxic in a dose and duration-dependent fashion. Moreover, in 2022 review, Brain Changes Associated with Long-Term Ketamine Abuse, a systematic review, published in Frontiers in Neuroanatomy, reported that the long-term recreational ketamine use was associated with lower grade matter volume and less white matter integrity, lower functional thalamocortical and corticocortical connectivity, and observed differences in both structural and functional neuroanatomy between the ketamine users and controls, and may explain some of the long-term cognitive and psychiatric side effects, such as memory impairment and executive functioning. Confused as to whether ketamine is a brain fertilizer that helps to regrow synapses and whether it's toxic to neurons. First, keep in mind that Yale psychiatrist John Crystal begins with "we think, not we know" in his statement. We think that one of the things that ketamine does that helps to explain its antidepressant effects is to help the brain to regrow the synapses, and psychiatrist Michael Benov, who tells us that ketamine is a brain fertilizer, is the medical director of Psych Atlanta, a ketamine infusion clinic. Still confused? Well, you might want to spend some time with recreational ketamine users to see if ketamine has improved or damaged their memory and executive functioning. I've already noticed this myself, what I've seen in people. What is especially troubling about the assumption that ketamine is a brain fertilizer that helps grow synapses is that it encourages heavy use of a substance that is now easily attainable. Psychiatric News reported in 2024 that nearly half, or 47% of individuals who are receiving ketamine therapy are doing so outside of clinical settings and in their own homes, ingesting a compounded formulation such as a lozenge or lollipop after being prescribed the medication via a virtual clinic. This should be extremely disturbing because it's uncontroversial that heavy use of ketamine results in damage to the bladder, and now many will have to wear nappies the rest of their lives. In 2025, Urology and Continence Care Today reported that ketamine bladders what community nurses should know. In recent years, the link between ketamine use and damage to the urinary tract has become apparent, with the estimation that at least 26 to 30% of users experience at least one bladder symptom. Using ketamine at least 3 times a week over a period of 2 years has shown to result in altered bladder function, with some patients complaining of severe urological problems. The syndrome is often called ketamine bladder or ketamine cystitis in the literature. In much of the world outside of the United States, the horrors of ketamine bladder are widely known. Of course, in the United States, people don't know and just accept side effects of pharmaceuticals. How to stop playing Whack-A-Mole. The alternative to a life of playing wacky theory and wacky treatment is to delegitimize the manufacture of the wacky game, establishment psychiatry, which is comprised of mental illness institutions that 1. Do not take science seriously, 2. Are corrupted by drug companies, and 3. Have an impoverished view of emotional suffering, behavioral disturbances, and of humanity, and 4. Do not adhere to what should be the first rule of medicine. Above all, do no harm. Before demonstrating these 4 sad realities of establishment psychiatry, it needs to be made clear that defenders of establishment psychiatry conflate establishment psychiatry with psychiatry. The reality is that there are psychiatrists who are embarrassed of establishment psychiatry. Psychiatrists who are critics of establishment psychiatry include Joanna Moncrief. She has not only debunked the serotonin balance theory in Chemically Imbalanced, but in previous books, has explained how psychiatric drugs do not cure any underlying diseases, but simply affect our feelings and behaviors in the same sort of way that alcohol and recreational drugs affect them. Other psychiatrists embarrassed by establishment psychiatry include Mark Horowitz and Joseph Whitdoring, who take seriously the scientific reality of psychiatric drugs and help people safely taper off of them. A handful of other psychiatrists have gone public with their embarrassment with establishment psychiatry, and there are other psychiatrists who are privately embarrassed but fearful of speaking out publicly against the following realities of establishment psychiatry. 1. Establishment psychiatry does not take science seriously. In addition to the previously noted disregard by establishment psychiatry for the fundamentals of science with respect to its theories of mental illness, it has little regard for the scientific method in its claim of treatment effectiveness. A major area of established psychiatry's disregard for science is its bastardization of the randomized control trial, RCT, which is a critical test to assess whether a treatment is actually scientifically effective. Any genuine scientist is aware of the power of patient expectations and the placebo effect, which can result in positive patient reports following any treatment, including bloodletting. So a genuine scientist takes seriously the essence of the RCT, while establishment psychiatry debases the RCT. Specifically, a trial is not a controlled trial unless the participant, subjects, and the researchers are truly blinded as to who is receiving the hypothesized treatment and who is taking the placebo. In establishment psychiatry trials of antidepressant drugs and other drugs, such blinding has routinely been absent because of easily noticeable side effects of antidepressants, result in patients uncertainty whether they are taking the drug or the placebo. A genuine scientist who actually wants to get to the truth as to whether or not a hypothesized treatment is effective takes special care into ensuring that subjects and researchers are truly blinded. This true blinding can be accomplished with what scientists call active placebos, for example. Instead of placebo sugar pills or saline solutions, substances used for placebos result in noticeable side effects. Such active placebos are not routinely used in establishment psychiatry's drug trials, which makes antidepressants' failure to meaningfully distance themselves from placebos, the clinically negligible nature of antidepressants, even more damning. The same disregard for the scientific method that establishment psychiatry evidenced in the standard antidepressant drug trials is now evident with ketamine. Psychiatric News reported in 2024 that PubMed shows more than 400 trials of ketamine as a depression treatment in the past decade. However, it also reports that Jace Caleb-Alexander, the co-director of the Center for Drug Safety and Effectiveness at Johns Hopkins, told them, much of the research is plagued by non-trivial limitations, including studies that were too short in duration, had too few participants, were conducted by researchers with conflicts of interest, had no active comparator, or failed to systematically and comprehensively measure safety. The deal breaker, he said, was researcher and participant bias due to lack of blinding. What does genuine scientific research on ketamine as a mean for depression look like? A 2023 Stanford University study, lead authored by anesthesiologist Teresa Lee, was designed to create a true RCT. Lee and her co-researchers used a subject pool of patients diagnosed with major depressive disorder who were scheduled to undergo surgery. This allows researchers to give all the participants standard surgical anesthetic with half randomly assigned to receive ketamine. And this created the type of blinding necessary for a true RCT. In comparing the effectiveness between the placebo group and the ketamine group, they concluded that a single dose of intravenous ketamine compared to placebo has no short-term effect on the severity of depression symptoms in adults with major depressive disorder. Our results suggest that ketamine may actually be ineffective for the short-term treatment of depression. Establishment psychiatry's routine bastardization of the RCT is only one of the many scientific reasons why their treatment effectiveness claims are meaningless. Antidepressant trials have been debased by the same previously noted issues that have debased ketamine trials: too short in duration, lack of blinding, conducted by researchers with conflicts of interest, and failure to systematically and comprehensively measure safety, along with other trial design biasing, for example, in outcome measures that dice load the favor the drug. In addition, establishment psychiatry researchers have resorted to overt scientific misconduct. In the 2006 Sequence Treatment Alternatives to Relieve Depression study, the highly influential year-long antidepressant study has been criticized as fraudulent. Study researchers did not adhere to their original protocol, and most egregiously, they moved a large group of subjects who were previously excluded as non-evaluable into the evaluable category, knowing full well that this and other maneuvers, such as switching outcome measures in mid-study, would dramatically inflate the remission rate. Even the STAR-D researchers' scientific misconduct inflating results. Their reported remission rate was still worse than the year-long remission rate of depression patients receiving no medication reported in 2006 NIMH study. 2. Establishment psychiatry is corrupted by drug companies. STAR-D researchers had extensive financial relationship with drug companies that manufacture the antidepressant drugs used in the study. However, such conflict of interest was not seen as unethical by their own establishment psychiatry. The American Psychiatric Association, the APA, the Guild of American Psychiatrists, is a key member of establishment psychiatry, and in the APA's commentary on ethics and practice, in the section Relations with the Pharmaceutical and Other Industries, it states, psychiatrists may interact with industry in many ways, including accepting personal and office gifts or corporate donations from that industry. While psychiatrists are advised that a conflicted interest has a potential for compromised integrity, The APA does not prohibit such conflict of interest, stating that the mere appearance of or existence of conflict of interest does not by itself imply wrongdoing. In defending their financial relationship between psychiatry and drug companies in 1992, the then APA medical director, Melvin Chaffin, called the relationship a responsible ethical partnership that uses the no-strings resources of one partner and the expertise of the other. The APA publishes the DSM Diagnostic Manual, and the PLOS Medicine reported in 2012 that 69% of the DSM-5 Task Force members report having ties to pharmaceutical industry. In 2004, Marcia Angel, the former editor of the New England Journal of Medicine, published The Truth About the Drug Companies. And she offered the following examples of drug company influence on another key member of establishment psychiatry, prestigious university psychiatry department. Angel reported that the head of the psychiatry department at Brown University Medical School made over $500,000 in 1 year just by consulting for drug companies that make antidepressants. And she noted, when the New England Journal of Medicine, under my editorship, published a study by him and his colleagues of an antidepressant agent, there wasn't enough room to print all of the author's conflict of interest disclosures. The full list had to be put on the website. In 2008, such corruption of psychiatric and drug companies is still considered news, as the New York Times published several articles about the 2008 congressional hearings on the relationship between pharmaceutical companies and establishment psychiatry, including key thought leaders, psychiatrists such as Harvard psychiatrist Joseph Biederman, who received $1.6 million in consulting fees from drug makers from 2000 to 2007. Such exposures led to federal legislation in 2013 requiring drug companies to disclose their payments to physicians, resulting in the creation of the Open Payments Database. In 2021, utilizing the Open Payments Database, journalist Robert Whitaker reported, from 2014 to 2020, pharmaceutical companies paid $340 million to U.S. psychiatrists to serve as their consultants, advisors, and speakers, or to provide free food, beverages, and lodging to those attended promotional events. Whitaker noted that approximately 75% of the psychiatrists in the United States received something of value from the drug companies from 2014 to 2020. Unfortunately, while the Open Payments Database has now made the corruption of psychiatry by drug companies easy to see, it has not stopped it. 3. Establishment psychiatry has an impoverished view of humanity. While establishment psychiatry claims to have a biopsychosocial view of mental illness, it has been dominated by a biological perspective, and in recent years, in the face of undeniable research and political pressure, establishment psychiatry has acknowledged the significance of trauma and adverse childhood experiences to later emotional suffering and behavioral disturbances, but this has made virtually no dent in establishment psychiatry treatment practices, which overwhelmingly consist of brief medical management adjustments to medication. With establishment psychiatrists' biological domination, other perspectives that fall outside of this monopolized one are denied and marginalized. So establishment psychiatry continues to ignore important psychological and social causes of emotional suffering and behavioral disturbances. Prior to the domination of the current perspective, psychiatrists would not be accused of being irresponsible for considering the idea that notions such as mental illness and mental health were meaningless, recognizing that all human beings are capable of deteriorations that cause suffering to themselves and others, and that any given society such deteriorations are often labeled differently, from sinful to criminal to unethical to mentally ill to successful. So when the U.S. society deteriorations into corruption or greed are not seen as mental illness, instead labeled as some sinful, criminal, or unethical, and increasingly rewarded with political and financial success. However, in another society, such deteriorations are evidence of a kind of mental or spiritual illness. And many indigenous societies would view thought leader psychiatrist Joseph Biederman very differently than the mainstream U.S. society viewed him. Biederman, as noted, received $1.6 million from drug companies from 2000 to 2007. And he is credited with creating pediatric bipolar disorder, resulting in millions of young children, including preschoolers, being psychiatrically drugged for such symptoms such as maybe a short temper or irritability or intense happiness or even silliness for long periods of time. In some indigenous societies, Biederman may well have been viewed as mentally or spiritually ill himself. In contrast to today's monopolistic biological error of establishment psychiatry, there were once several prominent psychiatrists who actually spent significant time with their patients, attempting to understand their lives, and who were interested in the complexity of human psychology. Some such psychiatrists called themselves psychodynamic, psychoanalytic, and analytic, and 50 years ago, following in the footsteps of Harry Stack Sullivan and his interpersonal theory of psychiatry in 1953, there were many well-known psychiatrists, including Eric Berne, Murray Bowen, Nathan Ackerman, Salvador Machin, Don Jackson, and Stephen Karpman, who observed interactions and transactions in families and other groups. Psychiatrists with an interpersonal, interactional, and contextual perspective distinguish between transactional and loving bonds, and recognize that emotional suffering and behavioral disturbances, rather than being the result of any biological defect, are often the result of dysfunctionality in families and in society, in which people were forced to be mere objects, devoid of much of their humanity. All this is to say that there were prominent psychiatrists, even throughout much of the 20th century, who did not have an impoverished view of humanity. For establishment psychiatry does not adhere to above all do no harm. Perhaps a more serious indictment of establishment psychiatry is it does not adhere to what should be the first rule of medicine, above all do no harm. There are multiple examples of this. For establishment psychiatry, treatment-resistant depression is defined as previously noted when at least 2 different antidepressants don't improve your symptoms, and that the standard of care options for treatment-resistant depression include electroconvulsive therapy, ECT, or ketamine infusions and injections. A practitioner who takes serious the rule, above all do no harm, takes special care to ensure that the likelihood of treatment benefits far outweigh the likelihood of adverse effects. However, establishment psychiatry does not follow this rule. The idea of defining a patient's depression as treatment-resistant because that patient has not gone into remission after 2 standard antidepressant drugs is not scientifically defensible. Research has shown that the benefits of antidepressant drugs are clinically negligible in comparison to a placebo in the short term, and worse than no medication at all in the long term. Furthermore, many adverse effects of antidepressants are uncontroversial. The percentage of sexual dysfunction from the antidepressants runs from 25 to 73%. Imagine how that affects someone's life and self-esteem and how they feel. According to a 2010 examination of several studies, the post-SSRI sexual dysfunction, in which sexual dysfunction exists even after the discontinuation of SSRIs, were first reported to regulators in 1991. When trying to reduce antidepressants, 56% of individuals experience withdrawal effects. And approximately 1 in 4 people will experience severe withdrawal symptoms for their treatment of their depression. Many establishment psychiatrists continue to ignore scientific realities of withdrawal, mistakenly assuming that withdrawal symptoms following stoppage of antidepressants are evidence of a depression relapse rather than the evidence of antidepressant withdrawal effects. However, withdrawal misery as well as sexual dysfunction are now widely acknowledged by at least some members of establishment psychiatry, which continues to deny research findings of the relationship between antidepressants with increased violence and suicide. It gets worse. After depressed patients fail to remit following standard antidepressant treatment that have not been shown to be scientifically effective and which have significant adverse effects, established psychiatry next recommends treatment with ECT or ketamine infusions, which also have not been shown to be scientifically effective and which have even more severe adverse effects. The lack of effectiveness and adverse effects of ketamine have been previously noted. ECT has also not met the scientific criteria for effectiveness, as a comprehensive 2019 review of the research on electroconvulsive therapy effectiveness reported that there have been no randomized placebo-controlled studies since 1985. And those studies were done prior to 1985 are of such poor quality that conclusion about efficacy is not even possible. Moreover, it's been consistently shown that ECT results in serious side effects, such as persistent and permanent gaps in life memories, including even of weddings and birthdays, somewhere between 12 and 55%, reported by psychologist John Reed in 2021, who also reported that 1 in 50 patients experience major adverse cardiac events. Similarly, the adverse effects of antipsychotic drugs as a long-term treatment for individuals diagnosed with schizophrenia far outweighs benefits. In 2007, a NIMH long-term longitudinal study reported that at the end of 15 years, among those patients who had stopped taking antipsychotic drugs, 40% were judged to be in recovery. This compared to only 5% in recovery among those who had remained on antipsychotic drugs in 20 years. The research Martin Harrow and Thomas Jobe reported that antipsychotics reduce or eliminate flagrant psychosis for most patients with schizophrenia at acute hospitalizations. 4 years later and continually until 20-year follow-ups, patients with schizophrenia not prescribed antipsychotics had significant better work functioning. Even though the Harab-Jobe study was NIMH-funded research, the findings were completely ignored by establishment psychiatry and only brought to public attention by Robert Whitaker in the Anatomy of an Epidemic, which after it was dismissed by established psychiatry for being merely longitudinal findings, however, an RCT study was applied to this issue by researcher Lex Wunderlich, who reported in a 2013 in JAMA Psychiatry that at the end of 7 years, the recovery rate of those who had been tapered off of antipsychotic drugs was more than twice as high as those who remained on them. The adverse effects of antipsychotic drugs were uncontroversial. They reported that the prevalence of antipsychotic-induced extrapyramidal side effects was considerably high, with 1 in 5 patients experiencing Parkinsonism and more than 1 in 10 patients experiencing akathisia. American Family Physician reported in 2010 the newer second-generation antipsychotics, especially clozapine and olanzapine, generally tend to cause more problems related to metabolic syndromes such as obesity and type 2 diabetes mellitus. All antipsychotic medications are associated with increased likelihood of sedation, sexual dysfunction, postural hypotension, cardiac arrhythmia, and sudden cardiac death. It's a sad history of establishment psychiatry, and it's a regular occurrence for them to swear by a treatment that does more harm than good. As late as 1969, one leading textbook of psychiatry lauded insulin coma therapy as a landmark in psychiatric progress, and lobotomies were still being performed in the United States throughout the 1980s and never banned. Game over. Establishment psychiatry is at one level unscientific, corrupt, impoverished, and damaging, and at another level it's just ridiculous. Instead of clinics of biological psychiatry wasting their time in the game of whack-a-mole, whacking the latest wacky theory or treatment that needs to be whacked down is establishment psychiatry. While it's easy to scientifically demolish the credibility of establishment psychiatry, critics of psychiatry have had to face establishment psychiatry's array of rhetorical fallacies, defenses, and attacks. One of the most frequently used rhetorical fallacies by establishment psychiatry to divert attention from legitimate criticism is an ad hominem attack of guilt by association, falsely connecting the author of a critique with a group abhorrent of much of the general public in order to not have to deal with merits of the critique. Outside of psychiatry, a well-known example of this is the augmentum ad nauseam, or playing the Hitler card, in which the diversionary counter to an argument for the merits of vegetarianism is something like, well, Hitler was a vegetarian. Establishment psychiatry and its mainstream media supporters have commonly responded to critiques of psychiatry with such associations to abhorrent organizations or individuals who happen to have critiqued psychiatry. The apparent group that has been commonly used is the Church of Scientology. Another diversion from criticism is used by establishment psychiatrists such as Awies Aftab and Ronald Pice, who claim to be open to criticism of psychiatry, but only if it doesn't delegitimize establishment psychiatry. Aftab and Pius distinguish between critics who are, in their words, sincere and well-intentioned critics versus those critics who are hostile. And vituperative rhetoric is clearly aimed at discrediting psychiatry as a medical discipline. This second group falls under the rubric of anti-psychiatry, which he defines as a movement denies the fundamental legitimacy of psychiatry as a medical specialty, consistently imputes malign and malicious motives to the profession, and which denies the efficacy and legitimacy of psychiatric treatment, particularly its somatic treatments. I'm adding this as my input that this is classic psychiatric gaslighting. Aftab and Pice conflate anti-psychiatry with anti-establishment psychiatry. Establishment psychiatry also routinely conflates anti-drug with anti-dishonesty about drugs. Some are aware of no critic of establishment psychiatry who is anti-drug and who does not acknowledge the possible short-term benefit of a tranquilizing drug in preventing hospital or prison incarceration. Unlike establishment psychiatrists, critics of establishment psychiatry, such as psychiatrist Joanna Moncrief, Mark